Okay, so let's dive into this next chapter on the menopause series. So we're going to talk about your body and menopause and all the different things that are going on in your body. The origin of menopause, what's going on in your heart, in your brain, in your bones, in your joints, and in your muscles, and what happens when we don't address these things. Again, we want to empower you with knowledge to really help you navigate through midlife and beyond. I think it's great when you can start off with this quote where it basically just says, you cannot outrun, out-earn, or out-exercise the big M, which is menopause. The menopause train's coming no matter what. All right, so if menopause is natural, why do you feel so terrible and why should you treat it? That's kind of the common question and a lot of the myths. So let's kind of really sit back and unbunk it. And I think it's important on the next slide when we kind of talk about this as not your grandmother's menopause anymore. Okay, so when we think about menopause today, it's really important to recognize that this stage of life has always kind of played a central role when we think about human evolution. One of the best known or most well-known theories is this grandmother's hypothesis, and what it suggested is that menopause evolved as a survival advantage. By living beyond reproductive years, grandmothers could help care for their grandchildren, and it increased their chances of survival for their genetic lineage. But studies supporting this showed that women who live longer and provide care from grandchildren also pass on a greater genetic legacy. But here's where the things get a little bit interesting. What was once an evolutionary advantage may feel like a mismatch in modern medicine times. Women are now actually living decades longer after menopause, even more than ever before. And instead of it being just this brief transition of an end-of-life phase, menopause has become a significant stage of life that can span 30, 40 years. It's also a time of just this recalibration. Hormone receptor sites start to downregulate, metabolism shifts, and the body adjusts to a new pattern of energy use. And for many women, this recalibration can feel very disruptive, but it also represents an opportunity to kind of just reassess health, the lifestyle, long-term wellness categories. And that's why we kind of say it's not your grandmother's menopause anymore, because today a lot of women expect more, not just survival, but they want vitality, longevity, and quality of life. I like to put this slide on here because it really kind of shows that menopause is having more than just a movement. There's lots of things on the internet. There's apps, there's movies, all different kinds of things that you can find in your drugstore, how to track your menopause. So trying to navigate through all this makes it a lot more difficult as we go through this transition. Also, it's hard to know, like, what's the Wild West out there? What is good information? What's bad information? And so that's why I'm glad that you're tuned into this series. Menopause is really that loss of our reproductive hormones, but it's also this time of opportunity for growth and learning, and that's exactly why you're here listening to these courses. These hormones really play a vital role in every part of our body, and every organ system is influenced by our reproductive hormones. So no two menopause journeys are going to be the same. So let's talk a little bit about hormones and what's going on in our body. I like to use this app out of the Balance app, and what it is it's a woman's life and hormones. And as you can see in our younger, more reproductive years, 20s, 25, 30s, you can see that there are a lot more higher levels of estrogen, progesterone, and then they really start to plummet when we hit that midlife transition into the 40s, 50s, and then later in life. We actually completely stop producing estrogen once we get into midlife, and believe it or not, we actually probably have more testosterone menopausally than we do estrogen. Testosterone, though, does start to steadily decline in those late 20s or into early 30s. And then you can also see that melatonin, which helps for sleep preservation, also starts to tank. The progesterone has a much greater fall drop-off than the estrogen levels, and that's often why in perimenopause progesterone works so well, because it's the first hormone that really starts to shift. So let's consider all the different roles these hormones play. So as we kind of think of midlife and menopause, it's important to remember that hormones are not just about reproduction. They influence almost every aspect in our system. Estrogen is often thought of as the main female hormone, but its role goes beyond that, far beyond that, for periods and fertility. It impacts bone density, brain function, heart health, skin elasticity, even mood regulation. So when estrogen declines in perimenopause and menopause, we start to see symptoms like hot flashes, sleep disturbances, and mood changes. And we also see an increased risk for osteoporosis as well as cardiovascular changes. When progesterone starts to decline, that also really influences things. Progesterone is thought of as this calming hormone. It tends to balance out the estrogen. It works on GABA receptors in our brain when it has a conversion over to allopurinol, and it really supports sleep and has this natural, almost anti-anxiety effect. So during perimenopause, progesterone is often the first hormone to decline, leading to symptoms like the irregular cycles, heavy bleeding, poor sleep, as well as irritability. And then testosterone is often a surprise to many people when I talk to them about it. What we see with testosterone is that women produce it too. I always say we shouldn't gender hormones, and it plays a really key role in muscle strength, bone health, energy, focus, sexual desire. And testosterone also declines with age. Many women may notice a decrease in libido, brain fog, or loss of muscle mass. So when we consider the role that these hormones play, it's really important that we understand just their kind of interconnected nature and how they shift and impact the way we feel, function, and the way we age. So I've put a couple different graphs on here on what's going on with the influences of estrogen. We'll look at the influences of progesterone and testosterone. But you can see with these influences of estrogen, it affects all the different parts: brain, our hearts, our liver, our skin, our joints, our bones, and kind of just what's going on with each of these parts and pieces with the hormone of estrogen. This also talks about just the influence of progesterone. What is progesterone, functions in, and low levels, what it causes. Obviously, fertility disturbances, heavy menstrual bleeding, definitely that heightened of anxiety, and what doing micronized progesterone can do for you and how that can help as well. We're going to talk more about these hormones, but in particular testosterone, really important for eye health, cardiovascular health. We only have a consensus statement really for use of it for libido, but it's beyond much more. I'll often call it a mood hormone. Really helps with mood and energy and our bone health. So the other part we're going to dive into next is just these different organ systems. When you start having the transition into menopause, there's lots of different things that can happen in that cardiovascular system. Arterial stiffening, diminished ability of our blood vessels to dilate. We see changes in lipid concentrations. A lot of patients come to me perimenopausally and they say, oh my goodness, I've never had issues with my cholesterol or lipids being elevated, and now I do. So it's definitely a time frame where things really do start to change. You can also see in here just the changes that happen with estrogen and that endothelial lining of the blood vessels. As estrogen starts to decrease, we may start seeing more changes of atherosclerosis because you have that changes that's going on in your lipid level. When we look at more of the lipids that are going on in your body, in particular the lipoprotein particles, those particles show kind of that stickiness of the blood. And the stickier the blood is, the more it makes you more prone to strokes and atherosclerosis. As you see, when your biology starts to change with your hormones, you got more inflammation, vasodilation, plaque instability. So again, estrogen really acts as this very much an anti-inflammatory hormone. The other thing that we see on this slide is the longer a woman was without her hormones, the higher her risk is of heart disease, but also of heart failure and atrial fibrillation. So it's really kind of important to kind of just know that every woman, as they go through midlife, really deserves this discussion and to really understand what's going on with her body. So cardiovascular disease, this is the number one killer in women. We often hear that women are so afraid of their hormones because of breast cancer reasons, but still the number one killer for men and for women is going to be cardiovascular disease. In fact, it kills one woman every 80 seconds, more than all the cancers, TB, HIV, malaria, breast cancer, all the things combined. Yet it doesn't get the same attention in women in the conversations like cancer does. What's even more concerning is awareness about it. About 56% of women overall and 36% of Black women recognize that cardiovascular disease is the leading cause of death in women. This is really alarming because nearly half of Black women are living with cardiovascular disease. And the reality is that 1 in 3 women will die of a cardiovascular type of disease. That's about 400,000 women per year. Pretty staggering, you know? Most of these events happen after menopause when those estrogen levels start to decline, because you have to remember women lose some of that cardiovascular protection that those hormones provide. So when we think about menopause, we're not just talking about hot flashes and night sweats. We're actually thinking of these real life-threatening risks with heart attacks and strokes. And I'm really hoping that doing this series is going to raise awareness. We're going to screen appropriately, and we're going to address these modifiable risk factors early on, because it's really essential to protecting not only our women's hearts, but also their long-term health. Let's talk a little bit about the brain and where your sex hormones are. You can see all these little dots all over here and what's going on in our brain. And when we talk about sex hormones, we often think about reproduction, periods, and menopause, but hormones are also really powerful brain modulators. So this image shows how estrogen, progesterone, and some of the other hormones affect multiple regions of the brain. You'll notice that every major area has some kind of connection to sex hormones. So when we look at these frontal lobes that regulate like decision making and focus, we also can look at the hippocampus that controls memory, the amygdala that manages emotions and stress. But during life changes, puberty, menstrual cycle, pregnancy, postpartum, menopause, and even the use of just oral contraceptives or hormone therapy, all of that creates these shifts in our brain and our structure and in our function. These hormonal transitions can explain why women often experience changes in mood and in their sleep and in their memory, and are even vulnerable to anxiety, depression, and other things. So, for example, during menopause, estrogen decline impacts that hippocampus and that frontal cortex, which is why so many women report brain fog, memory lapses, difficulty with concentration and word recall. And similarly, when we look at postpartum hormonal changes, that affects the amygdala and that emotional regulation. So what I want you to understand here is that hormones just don't act below the neck. They have a profound influence on the brain in shaping our cognition, our emotional well-being, and just our overall health span or lifespan. Diving a little bit farther into the brain, when a woman transitions into menopause, the brain goes through some measurable structural and functional changes. We see a lot of loss of what's called gray matter, and that's the actual brain cells that process and transmit information. And then we have white matter, which is the wiring that connects those cells. This combination can contribute to the classic symptoms that many women describe, such as brain fog, trouble concentrating, and these memory lapses. We have another shift in how the brain metabolizes energy. The brain depends really heavily on glucose as its main fuel source. So when you think about it, you eat something, your body breaks down glucose, but that glucose goes throughout your body, but our brain really relies on it. So during and after menopause, glucose metabolism is really, really critical in the regions of the brain where it drops significantly. So the decline in the energy supply, that can affect our focus, our memory, and our mood. And we know that the activity level of a key metabolic enzyme, it's called mitochondrial cytochrome oxidase, I know, big word, that starts to decrease. This enzyme is really essential for producing cellular energy, lowering activity, and here it's linked not only to reduce brain energy, but also to lower cognitive performance and standard memory and cognitive tests. So these changes that are going on in your brain, it's just kind of a reminder that menopause is not just about your reproductive hormones, it's whole body, whole brain transition, and really understanding that. So when we talk about brain health in women, there are some striking and concerning statistics. More than 2/3 of people are diagnosed with Alzheimer's disease, and those 2/3 are women. While part of this is explained by women living longer than men, longevity is not the whole story. Biological sex differences, hormone changes, cardiovascular health also play major roles. Women are also twice as likely to develop a major depressive disorder, and often this occurs in tandem with cardiovascular disease. When depression and heart disease occur together, the risk of dying from cardiovascular disease increases 5-fold. So it's really important to remember heart disease in itself is a risk factor for Alzheimer's disease. And that means that protecting cardiovascular health in midlife is one of the most powerful ways that we can protect long-term brain health. So when we think about menopause and women's health, we need to expand the lens. It's not just about hot flashes and bone density. It's about our heart and our brains, and they're all intertwined, and how these risks disproportionately impact women. All right, so let's dive into a little bit of mitochondria. Those are our cells, and mitochondria is kind of this powerhouse of our cells, and it produces ATP, which is what we need for energy. So during the perimenopause, high levels of energy are paralleled by this normal mitochondrial activity with a balanced work on homeostasis and high brain energy metabolism. At the beginning of what's called reproductive senescence or perimenopause, there's a decrease in these estrogen levels, and it's accompanied with this increase of oxidative stress. And what that does is it causes some issues. During aging and alterations of the mitochondrial membrane, lipid profiles start to change, cells start to possess compensatory mechanisms, and a lot of antioxidant defenses. And these are really important because they're really trying to keep our system in balance. So in cases of compensatory system, it becomes exhausted. You see some of these metabolic impairments that start to go on. And that happens because the ATP levels, remember I said those are for energy, those start to decrease. You have glucose changing. And what's going on is you're seeing lots of impairments that are going on in the body. In parallel, you have this increase of expressive genes involved in the fatty acids and oxidations. And this is kind of this critical period. And you can see it there with this blue arrow. It indicates this really fast drop in our estrogen levels in a really short amount of period of time. And what it's suggesting is a period of a woman's life where they're more vulnerable and more likely to develop some of these maybe age-related disorders. So more increased risk for things maybe like Alzheimer's disease. Estrogen replacement could be really beneficial for women before they reach that critical threshold that causes that cellular damage during perimenopause and early menopause. So these are just really important things to kind of just understand and have in your arsenal. In terms of your immune system, estrogen doesn't just influence reproductive health, it has a major impact on our immune system. This slide really kind of highlights in particular 17-beta estradiol, or what we call E2. This is what we naturally make in our ovaries. It's the primary form of estrogen, and it interacts with our immune cells, and depending on the estrogen levels, it can shift the balance of immune response in powerful ways. It can cause certain T cell responses, boost antibody production from beta cells, and that may help explain why women often have a much stronger immune response to infections and vaccines maybe compared to our male counterparts. But the same strength in that immune system may also make women more prone to autoimmune conditions, lupus, rheumatoid arthritis, and thyroid disease. So estrogen can also affect inflammation, as you've heard me say. It can really suppress that pro-inflammatory signals, and it means that estrogen can help really us respond to injury and infection when it is stable. So during menopause, as those levels start to decline, we lose some of that immune regulation. And what's going on is that can contribute to that increased inflammation. You heard me say increase in cardiovascular disease, increases in cholesterol. So when we think about estrogen, it's not about our bones and our skin. It's just these immune regulators that help keep our system in balance. I also think it's important to talk about this musculoskeletal syndrome in menopause. It really affects this acceleration of bone loss as our estrogen starts to deplete. 20% of loss of bone mass from menopause to age 60, which is pretty significant. 1 in 10 women greater than 60 have osteoporosis, and 1 in 2 women aged 50 years or older will sustain an osteoporosis-related fracture. That's huge. Lots of hip fractures, very much impacts quality of life. 50% of women are reporting some form of arthalgia or joint pain during this transition, and it really peaks a lot more as they get into that 50 and 60-year-old compared to men. So there's this loss of collagen, loss of estrogen, and also this increase in inflammation, making it more prone to osteoporosis and osteopenia and that musculoskeletal achy joint syndrome at menopause. You can see here in this slide just all the different things that estrogen is doing in our bones and in our muscle mass and why it is so important. Along with estrogen, progesterone and testosterone really help to stimulate these various pathways and cells within our bone and muscles. And that's why, again, it's so important for all these different hormones. Here I'm just going to put there's lots of different risks that happen as we go into this menopause transition. You've heard cardiovascular disease, dementia, osteoporosis, osteoarthritis, sarcopenia, which I kind of call that skinny fat, where you start to lose a lot of your muscle mass. rheumatoid arthritis, autoimmune disease, some inflammatory bowel diseases and GI changes, some psychological things that are going on as well too. I think it's also important to point out that there is this hot flash connection. These severe hot flashes and night sweats, we often just think about it as, oh, not a big deal, you'll get past it. But there is a lack of estrogen in our brains as we go through this transition. So when we're having this heightened hot flash experience, it can heighten inflammation and adverse health outcome. Again, higher risk of cardiovascular disease, risk of Alzheimer. Our brains get really starved for estrogen during this transition. Higher systolic and diastolic blood pressures, more prone to insulin resistance and metabolic syndrome, lower bone mineral density, bone fractures, and osteoporosis. So I hope you understand at the end of this that the cost of not treating menopausal symptoms is really costly. 1.5 million more outpatient visits per year with untreated vasomotor symptoms, 2,000 more per patient per year in medical expenses, lower quality of life scores, worsening chronic conditions. So again, this is such an important discussion to be having. But it's not all doom and gloom. It's really a time of opportunity. So we're going to spend more time going over in the next chapters on really how to free yourself of feeling this doom and gloom and having a place where instead of not feeling like yourself, that you're getting care that's optimal. So what we're going to focus on next in the upcoming chapter is the menopause consultation and what that looks like.